Good afternoon, and thank you for joining us for the Webinar Wednesdays with PKD Foundation Chief Scientific Officer, Dr. David Barron. We're excited to be back. During the presentation, please type your comments and questions into the chat panel on the right side of your screen or tweet us at PKD Foundation using #Webinar Wednesday. We will have a Q&A at the end to answer as many questions as we have time for. Please note that the PKD Foundation does not offer medical advice, and the information shared this afternoon is not intended to be a substitute for consultations with your health professional. Care and treatment decisions related to your health must be made in consultation with your health professional team. We are recording this webinar and will archive the recording on our website within the next few days. Today we have a guest speaker. Timothy Kline, Ph.D., is an assistant professor of radiology at the Mayo Clinic. Dr. Kline is one of our PKD Foundation-funded researchers. His project, Development of a Computer-Aided Decision Support System for PKD, looks at total kidney volume, or TKV, as it has become the main image-based biomarker for following AD-PKD progression. His project looks to develop automated tools to increase measurement throughput and explore new image-based biomarkers that will significantly add to the assessment of patient prognosis. It will also have the ability to more quickly judge the effectiveness of interventions. And now I'll hand this over to Dr. Kline so he can explain what that means. Dr. Kline, I'm making you the presenter. You should be ready to go.
Okay, can you see my slides?
Yes, we can.
All right. Well, hello and welcome to this month's Webinar Wednesday supported by the PKD Foundation. I'd first like to thank the PKD Foundation for all of the work they do in providing information and support to people affected by PKD. In addition, being an early career scientist, their support of my research has been essential in developing my research program, which is focused on advancing imaging to facilitate clinical management of PKD, as well as improve clinical trials by developing automated methods of measurement and improving the amount of information provided and extracted from radiological images. One of the biggest difficulties for PKD management is the fact that the time course of the disease is highly variable and not fully understood. Renal function, for example, estimated eGFR, may be stable for many years until a rapid decrease is observed as kidney function progressively declines. Total kidney volume, measured by magnetic resonance imaging, computed tomography, or ultrasound, predicts the decline of renal function and is used to ascertain the effectiveness of treatment interventions. Recently, the U.S. Food and Drug Administration and the European Medicines Agency qualified TKV in combination with patient age and eGFR as a prognostic imaging biomarker for PKD research and clinical trials. Particularly, height-adjusted TKV has been shown to be the strongest prognostic biomarker of renal function worsening and progression to end-stage renal disease in patients at an early stage of PKD when eGFR is within the normal range. Therefore, the accuracy and reproducibility, as well as the speed by which TKV can be measured, is critical. Due to its superior soft tissue contrast, as well as the fact that it does not use ionizing radiation, magnetic resonance imaging is the modality of choice for measurement of TKV, particularly for use in clinical trials where many scans and years of follow-up are used to assess treatment efficacy. Current methods to estimate TKV using MR images include volume calculation by the Ellipsoid Method, stereological approaches, and manual planimetry tracings. The Ellipsoid Method makes a number of measurements of kidney length in different directions and then approximates the kidney volume as an ellipse to determine TKV. The Ellipsoid Method takes a trained analyst around 7 to 10 minutes to perform the measurements and derive TKV. Shown here are the measurements made in the sagittal plane, the coronal plane, and the axial plane, as well as how these measurements can be used to calculate TKV. The stereology approach overlays a grid of points on the image, and a user highlights the points corresponding to the kidney. The number of points and the size of the grid spacing is then used to determine TKV. The stereology approach takes an analyst around 20 to 40 minutes to move through each slice of the image, highlighting grid points and deriving total kidney volume. The approach of planimetry requires a user to trace the border of the kidneys in each MR slice. This method takes a trained analyst 30 to 90 minutes to perform. The method of planimetry takes on many different names, including manual segmentation, because the method seeks to segment the kidneys from the surrounding anatomy. Each one of these techniques has trade-offs in terms of the time needed to perform the measurements, as well as the accuracy and reproducibility in the measurement of total kidney volume. Planimetry has become the method of choice due to its superior accuracy. However, the time it takes for a trained imaging analyst to trace the kidneys in each slice of the image is on the order of 30 to 90 minutes. Therefore, automated approaches where a computer helps perform the kidney tracings are highly desirable, both from a time perspective as well as from a reproducibility perspective, since a computer with a defined algorithmic approach will generate the same answer every time. However, automating the segmentation of PKD kidneys is challenging due to a number of factors. For instance, the shapes of the kidneys are highly irregular, and the contrast at the border of the kidneys is highly variable at the interface of several different tissue types, including fluid-filled cysts, calcified cysts, renal parenchyma, and fibrotic tissue. To overcome these problems, we developed an image processing approach to produce robust and reproducible measurement of TKV in follow-up image examinations given a single initialization tracing at one point in time. Shown here are snapshots along the algorithmic approach for automatic measurement of TKV in MR images of follow-up PKD patient examinations. The approach begins with the baseline scan in panel A and follow-up scan in panel B. The follow-up scan is first registered to the baseline scan. This process of registration is an algorithmic approach to align two different images by allowing one of the images to be stretched, shifted, and warped in order to best match the other image. Shown in panel C is the result of aligning the two images. The purple or green colored regions highlight slight misalignment between the two. Using the information from the registration procedure, the baseline segmentation in panel D is warped onto the follow-up scan shown in panel E. This warp segmentation then goes through an edge detection approach to finalize the segmentation as shown in panel F. To further explain the method, here is a short animation of the approach. Our automated approach begins by registering a patient's follow-up image examination to their baseline exam. These registration approaches begin by translating, scaling, rotating, and shearing the image volumes to find the best overlap between the two images. The image is lastly deformed to allow changes in kidney shape. After registration, the baseline segmentation is warped onto the follow-up scan using the information generated by the registration process. The warp segmentation is then used as the initialization to an edge detection approach that finds the kidney's borders to finalize the segmentation of the follow-up examination. Therefore, following an analyst's initial segmentation, this approach is completely automated and can be used to follow kidney volume changes. The way that we validate these automated approaches is by comparison with the results obtained from trained medical imaging analysts. In this study, we had two different analysts perform segmentations in order to establish the ground truth by which we judged the accuracy of our automated approach. The difference between the two observers is called the inter-observer variability. We also had the same analyst perform segmentations at two different times at least a month apart, in order to assess the variability in the same person performing the measurements. Shown here are example visualizations of the automated segmentation results for 3 different patients. Shown in the left column is the original T1 weighted MR image. The middle column shows comparison of the manual segmentations obtained by 2 different observers, the blue and red overlays. The blue overlay was used as the ground truth. Shown in the right column is the automated compared with the ground truth manual segmentation. The purple regions are shared by both of the segmentations. We found that the developed method allows accurate kidney segmentations, and that the comparison with ground truth segmentation showed that the method is within expected inter-observer variability. We have since published on this work, and this approach has been externally validated and is now facilitating both internal and external research studies where accurate automated segmentations are needed to follow PKD progression. After developing an automated approach to follow kidney progression, we next sought to develop a technique to improve the speed and reproducibility of TKV measurements when no prior exams are available. Towards this direction, we developed an efficient tool that measures cystic organ volumes. The MIROS program requires a user to create a crude polygon outline of the cystic organ as it scrolls through slices, and it provides efficient editing tools to further refine segmentations if needed. This program significantly reduces processing time from the order of an hour to a few minutes. It also provides accuracy comparable to 2 different people performing the measurements, and it's extremely easy to use. We've developed an image analysis toolkit which allows interactive viewing of the images, as well as efficient segmentation editing tools. The MIROS program is also incorporated into the viewer and is activated with a simple push-button tool. The MIROS program removes many of the components that make performing kidney tracings time-consuming. The program begins by showing the user the middle slice of the images. A user provides a crude polygon tracing around one kidney and then around the other. The program then moves a number of slices away, and the user again provides crude input for the program. The program then uses a series of automated approaches incorporating the user input to finalize the segmentation. Shown here is the result of the automated approach, as well as visual comparison with gold standard obtained by a trained imaging analyst performing a complete manual segmentation of the kidneys. Besides improving measurement throughput, the approach also helps remove variability in the measurements. Shown here are 2 very different polygons provided by 2 different users in red, along with the MIROS-generated segmentation. Comparison with ground truth segmentation showed that the MIROS approach significantly reduced measurement variability, meaning that 2 different analysts could provide rather different input, and the MIROS program would arrive at a very similar final segmentation, and thus measurements of TKV could be made much more reproducible. The approach is also being used for segmentation of polycystic livers, as well as on different imaging types, such as T1 MRI and CT. This approach is also being used now to facilitate studies where accurate automated cystic organ segmentations are needed. Due to these developments, we've been able to acquire a large database of ground truth segmentation, which can be used by next-generation image processing techniques. I've been developing a deep learning approach, which will be fully automated, and we hope to apply to the task of kidney and liver segmentation. The preliminary work was presented at the Machine Intelligence in Medical Imaging Conference in the fall of 2016. However, all of these automated methods currently will be used to derive TKV, but there are certainly a number of possible imaging biomarkers beyond TKV which may be useful for disease prognosis, as well as judging the efficacy of treatment interventions. As we know, the story is much more complicated than simply how large the kidneys are. For instance, differences in number, size, and composition of cysts is important information that helps drive clinical decision-making. Therefore, to go beyond TKV measurement of the cystic burden of the kidneys, including quantification of the number, size, and composition of renal cysts, should be added to our PKD image analysis protocols. This could lead to a deeper understanding of a patient's particular phenotype in terms of whether, for example, their kidneys are composed of a few large, simple exophytic cysts, or whether they have numerous complex, for example, proteinaceous cysts. However, performing segmentation of renal cysts from radiological scans of ADPKD patients is extremely time-consuming and challenging, particularly in patients with a moderate to severe cyst burden. Therefore, automated approaches are being actively pursued. We have, for instance, developed an approach which uses two routinely acquired MR images known as T1 weighted and T2 weighted images. Typical cysts appear dark in T1 and bright in the T2 image. However, here you can see a more complex cyst with high protein content, which appears bright in T1. The program that we've developed automatically performs cyst segmentation and classification, separately distinguishing this complex appearing cyst. Another opportunity is to explore next-generation imaging techniques, which can provide additional insights into renal structure and function. One technique we are exploring is known as magnetization transfer imaging, which is a form of MRI. This technique, we have shown, has the ability to extract information regarding fibrosis or scar tissue within the kidneys, as well as probe microscopic cysts. The MT imaging technique obtains two images and performs a subtraction between the two in order to obtain an image related to the macromolecule contents of the tissue. Another imaging technique we are exploring is known as blood oxygen level dependent imaging, or BOLD. BOLD imaging characterizes tissue oxygenation status. A reduction in the BOLD parameter, which is known as R2 star, would suggest an alteration in tissue resulting from decreased vascular density and/or changes in tissue viability. Therefore, we developed an extensive MR imaging protocol that explores a number of quantitative MRI techniques in order to test the reproducibility of the approaches, as well as explore their utility in imaging the PKD kidney. We performed imaging on 10 young ADPKD patients with normal renal function and 10 age and sex-matched normal volunteers. We characterized the reproducibility of the approach by imaging the matched controls on two separate occasions, and we explored whether there existed measurable differences in the non-cystic renal parenchyma between the PKD patients and the matched controls. We performed a comprehensive image examination which included traditional T1 and T2 weighted MRI, along with 2D phase contrast imaging to measure renal blood flow. We tested 4 new quantitative imaging techniques: diffusion weighted imaging, blood oxygen level dependent imaging, magnetization transfer imaging, and MR elastography. Shown here are the conventional T2 weighted images of ADPKD patients and their age and sex-matched control volunteers. A wide range of disease severity was observed in this cohort of young PKD patients between the ages of 18 to 30. Shown in the bottom left are the age and sex, and in the bottom right corner is the height-adjusted total kidney volume. High reproducibility of the quantitative measurements was obtained in the healthy group. The reproducibility in all 4 quantitative MRI protocols was comparable to, and in some cases better than, the traditional MR-derived biomarkers of total kidney volume and renal blood flow. We measured the quantitative MRI values within non-cystic renal parenchyma in the ADPKD patients. We found that statistically distinct measurements between ADPKD patients and normal volunteers were obtained by BOLD, DWI, MT, and MRE. bold imaging characterizes tissue oxygenation status, and in this study we found a reduction in the bold parameter, R2 star, which suggests tissue alteration possibly resulting from decreased vascular density and or changes in tissue viability. Similarly, with DWI, we found a reduction in the pseudodiffusion component, which is a surrogate measure of tissue perfusion, as well as a reduction in the derived perfusion fraction, which, taken together, are compelling evidence for changes in vascular structure and function. The reduction in MTR, which is measured by MT imaging, likely results from sub-resolution cysts, contributing to a reduction in signal, highlighting the possibility that MT imaging could be a better surrogate measure of cystic burden, for example, compared with segmentation of cysts in T2-weighted MR images, as has been done in the past. Lastly, MRE found a reduction in tissue stiffness of renal parenchyma in 80 PKD patients compared with the volunteers. How these parameters change with disease progression, disease severity, and capability to further refine disease prognosis certainly needs further study. The last component of my PKD Foundation research project that I'll be discussing today is related to next-generation image processing techniques. These are techniques that I am looking at because they can be applied to routinely acquired imaging data, and thus a large range of potential retrospective studies are possible. Advanced image processing techniques offer a unique opportunity to retrospectively explore the large number of imaging examinations available and correlate this information with known progression of the disease. Texture analysis is one technique which performs an ensemble of mathematical computations to greatly increase the information provided by conventional radiological images. We have examined whether image textures can serve as imaging biomarkers in PKD. We hypothesized that texture-based imaging biomarkers provide quantifiable parameters of renal tissue structure that will better classify patients and improve individual prognosis compared to TKD. A retrospective cohort of patients from the Consortium for Radiologic Imaging Studies of Polycystic Kidney Disease, also known as the CRISP study, was identified who had T2-weighted MRIs and typical presentations of the disease. Based on their eGFR measurements that were performed 8 years later, the patients were split into two groups according to whether they had or had not reached CKD stage 3A, CKD stage 3B, or had a reduction in eGFR of more than 30%. Now, image texture refers to the appearance, structure, and arrangement of different intensity levels within an image and has been used in organ segmentation tasks as well as clinical decision-making, for example, in classifying breast tumors, early diagnosis of multiple sclerosis, and differentiating liver lesions. Texture images are calculated by applying specific filters to the image, some that capture changes in intensity, and some also capture spatial relationships between different regions within the image. Shown in the left panel is a T2-weighted MRI of the kidney of one of the patients in this study. If we consider two different cystic regions, which are the zoomed-in panels, the information in terms of the image intensity is similar. However, in the two example texture images of entropy, which is in the middle panel, and energy, which is in the right panel, information regarding the size and position is ingrained in the image. Notice how the two cyst regions look very different in the texture images, and thus quantifiable values can be extracted which convey tissue structural information, such as cyst size and number. Other structural tissue changes, for example, fibrotic tissue or cyst classification, could likely be conveyed within the texture images. Shown here are examples of the 9 derived imaging texture features for a single patient. From the top left, by row and then column, we have the T2-weighted MR image from which grayscale values are extracted and the texture analysis is performed. Next is entropy, which measures the degree of disorder within the kidney. Kidneys with seemingly random distributions will have a higher entropy measurement. Note how large cystic regions appear dark whereas in regions of many small cysts, a high entropy value is calculated. The next is gradient. It is a measure of grayscale changes. Kidneys with many small cysts will have more detectable edges and larger local changes in grayscale. Next is contrast, which measures local variations. Low values mean that the gray levels are similar throughout the kidneys. The next is dissimilarity, which relates to a measure of renal tissue heterogeneity, which is inversely related to homogeneity. Note how both large cystic regions as well as regions with no cystic burden appear bright in the homogeneity texture image. The next is energy, which is a measure of tissue uniformity. It's closely related to the inverse of entropy. The next is correlation. It measures grayscale value dependence of the kidney voxels. And finally, the angular second moment, which is also a surrogate measure of tissue homogeneity. So we performed a regression analysis comparing individual biomarkers to the percent change in eGFR that was measured 8 years later. Shown here are the regression analysis results comparing the baseline traditional biomarkers such as age, baseline eGFR, and height-adjusted total kidney volume to the percent change in eGFR at 8-year follow-up. Age in the top left and baseline eGFR in the top right have very low correlation, whereas height-adjusted TKV, which is in the bottom left, has a fairly high correlation with a subsequent percent change in eGFR. A multiple linear regression model incorporating these biomarkers is shown in the bottom right panel. This data highlights our lack of refined tools to accurately predict subsequent disease progression based on current metrics. Individual texture biomarkers showed strong correlation with subsequent percent change in eGFR. Shown here are the regression analysis comparing texture biomarkers of entropy, correlation, and energy to the percent change in eGFR at 8-year follow-up. Shown in the bottom right panel is the multiple linear regression model incorporating traditional biomarkers and the texture features. Really, the most important result of this study is that we found that incorporating just 3 image texture features into a model to predict subsequent disease progression saw significant improvements to the prediction model. This multiple linear regression model incorporating image texture features helped further refine prediction of subsequent renal function decline. Thus, it appears the addition of image texture features into current prediction models is a promising approach and should be studied further. So in summary, we are working to develop automated analysis techniques that will improve measurement, speed, accuracy, and reproducibility, in particular for measuring total kidney volume. We are also searching for new imaging biomarkers that allow for more informed clinical management and can also help us improve the judgment of treatment efficacy. And finally, novel image processing techniques, as well as new imaging protocols, are promising and should be further explored. And with that, I'd like to thank you so much for your attention, and I welcome any questions at this time. Thank you.
Thank you, Dr. Kline.
Hi, Dr. Kline. One question that came up rather early, and I think the answer is pretty straightforward, is do any of these techniques require gadolinium or other radio-opaque dyes?
No, they do not. So we are specifically working with non-contrast enhanced MRI.
So, in other words, the advantage to MRI is, and doing it frequently in the course of the disease, either for clinical trials or for clinical use, is that the patients are not subject to either ionizing radiation or the toxic effects of dyes like gadolinium. Is that correct?
That is correct, yes.
So I had a couple questions, and could you explain a little more about what elastography is?
Yeah, MR elastography is actually a measure for tissue stiffness, and it was developed in particular for looking at stiffness of the liver. But the images are actually acquired while palpating the kidneys. So you can actually use this technique to derive the stiffness of tissue. One of the particular difficulties, I think, with the application in PKD is the limits in terms of resolution. And in PKD, we're kind of looking at the trade-off between trying to measure cyst versus something like elastography, which might help us characterize fibrosis. So I think at this time, resolution may be a limiting factor in applying MR elastography, in particular to measure something like renal fibrosis.
So in your pilot study where you looked at relatively young patients, 18 to 30, and their age-matched controls, the magnetization transfer variable seemed to be decreased in the PKD patients. Does that mean more or less fibrosis?
So in this case, with MT imaging, you would see if fibrosis was the dominant tissue alteration that was going on, you would expect to see an increase in the MT signal. However, as you said, and as we measured, when we tried to look at even the non-cystic regions, or what were observably non-cystic regions within these young patients, we were still seeing a decrease in the MT signal, which suggested to us that what we were actually likely characterizing was more microscopic cysts that were actually below the actual resolution of the imaging technique, and thus not seeing much in terms of fibrosis.
Go ahead.
Well, so I think that brings up an interesting question in terms of that we probably need to look at, in particular, MT imaging in older patients where fibrosis might be a larger contributor to renal function decline.
So that was really my next question. Do you have any anecdotal information about older patients that you may have had a chance to look at?
Unfortunately, not at this time, but we are planning on looking, particularly even looking at differences between PKD1 and PKD2 patients, where we might expect closer to end-stage renal disease when we're seeing some decreases in total kidney volume, that likely fibrosis is taking over. So this is sort of one of our next steps that we'd like to pursue.
And I try not to make a technical question, partly because I don't understand it, but the three variables that are highly correlated using texture analysis, how do they correlate with total kidney volume as determined by your automated system?
Yeah, that's a great question. So there's some correlation, but we were actually, I can't remember the numbers offhand, but the reason that I think the texture measures are able to help further refine our prediction models is that they're only loosely correlated with total kidney volume. So that allows them that they're actually characterizing something else about the kidneys beyond just purely the size. Obviously, if they were highly correlated with TKB, they wouldn't add much to our current prediction models.
So TKB is still a critical variable in the study of PKD.
Yes. Yeah. I think that is true, but I think some of these newer measures could help us further refine, what's going on with the kidneys, because, we really need to have some measures that can tell us more about, maybe whether the patient just has a few large exophytic cysts that are contributing to a large total kidney volume, and thus, they're likely going to do fine for a very long time. But total kidney volume really doesn't get at that point. So we're really hopeful that, something like texture, or, even just doing a better job at overall measuring the cystic burden of the kidneys can help us do a better job with disease prognosis.
And we have a couple questions from the audience. One is, are you using a 1.5 Tesla or 3 Tesla machine? And does that really matter in your analysis? And do other sites that use MRI routinely, do they have the equipment that you use so that they could use this technology as well?
Yeah, so when we think about there's two sides of my research coin, I guess. One is the automated approaches, and then the other is looking for new imaging biomarkers. And a lot of what's been developed was on earlier studies that were performed on 1.5T, but a lot of what we're doing currently is on 3 Tesla. My main comment would be, for the automated approaches, we're really seeking to create generalized tools. So we're working with a number of external sites, that maybe perform on different scanner vendors or different field strengths, but attempting to create these tools that can work under both of those circumstances. I would say regarding the texture analysis approach, or trying to look at, deriving some of these parameters out of the images, consistency would be pretty important. So, something that's, you find something about entropy, for example, on a 3 Tesla, I think you'd still have to validate on different equipment and make sure that you're seeing the same thing. So I hope that answers that question.
A follow-up question from the asker of the previous question is that for magnetization transfer, are you using a broadband frequency or a selected specific frequency?
So we're using a relatively broad band. If they're referring to the offset pulse, I think we were using 1500 hertz. And we had also done a fair amount looking at optimizing in some small animal studies, but obviously the offset frequency pulse does matter on what field strength magnet that you're working with.
And going far afield from these technical questions, we have a question from a patient who has kidneys that are really becoming too large for her body. Is there anything that you've seen in your experience in imaging polycystic kidneys that give information as to whether this is truly an acute medical issue, or can you contribute at all to the medical treatment of patients like that who have extremely large kidneys?
I don't know if I could necessarily answer that question.
Okay, and going back to the technology question, the person asking has viewed several MRI training videos at the NIH Library of Medicine, but this was several years ago, and one of the trainers found more artifact on 3T MRI, although higher sensitivity on 3T MRI. Has that been your experience, or have things gotten better even in those few short years. I know technology advances pretty quickly.
Yeah, no, I think that's a good point. That definitely is the early experience. I'd say now we have pretty good imaging sequence protocols that alleviate a lot of the initial issues with performing the scans at 3T. So I think a lot of that has been alleviated. And I could even field some of those offline too if they're interested. Sounds like some good technical questions.
Yeah. So going forward, I mean, this is very exciting, particularly because there's an ongoing search for not just a prognostic biomarker for which TKV has been approved, but an actual surrogate endpoint. Is it your feeling that, in particular, these texture biomarkers might contribute to a structural surrogate endpoint for this disease that doesn't necessarily take into account GFR, because early in the disease, GFR may remain basically stable and normal?
Yeah, I definitely think that you know that is a hope with some of these measures, and you know that's why we at least initially looked at sort of this retrospective study where we had these scans that were performed 10 years ago, and we could then calculate texture on those, and then look 8 years out to see how they informed on the subsequent disease progression. So really the next stage now is number one, to look at how do these individual texture parameters progress with the disease in individual patients, and whether they can help in treatment studies to potentially help with determining which patients will benefit the most from a treatment intervention.
And we do have one other question from the audience. Have these data been presented to the FDA? And I guess a related question, are you planning to do larger studies to refine these data?
So this data has not been presented to the FDA. I guess I'm wondering, are they wondering in terms of the automated tools to develop FDA-approved software? I don't know if they can answer in real time, I guess.
They might be able to, but my interpretation is that TKV together with the texture analysis may be a more refined tool that would give the FDA more confidence in a structural biomarker, so that it's not just a prognostic biomarker, but perhaps a surrogate endpoint which could define when treatment would start, assuming that we had an available therapeutic. And
yep.
This is exciting.
Yeah, I think that's a great point. So I think that should be pursued, yeah.
Well, if there are no other questions, thank you very much for what's going on with radiology and PKD. I think this is very exciting and will really help to develop new therapeutics and determine when those therapeutics should be given to patients. So I really appreciate your work and taking the time to explain what you're doing. Thanks very much, Dr. Kline, and perhaps we'll hear from you again in the future.
Yeah, thank you so much. This has been wonderful.
So thank you, Dr. Kline and Dr. Barron. I'd also like to thank our audience for participating in this webinar and for the wonderful questions that you submitted. If you need to reach out to us directly, please email us at education@pkdcure.org, and a member of our education team will get back to you. On behalf of everyone at the PKD Foundation, thank you for joining us today.